Dr. Anas. Dr. Anas Aldehashi is an assistant professor at Dammam University. He's a physiotherapy consultant. He has a special interest in exercise physiotherapy. He will talk, inshallah, about the physiotherapy and its role in rheumatology. Welcome, Dr. Anas.
Thank you so much. First of all, I'd like to thank the organization committee for inviting me for this an excellent event, and they just allow me to do something. They asked me to present in physiotherapy and rheumatoid arthritis. As a physiotherapist, we are receiving either rheumatoid patients or any immune patients. Once we starting to having a protocol, we are facing one thing that with many patients. This is why I changed a little bit of my presentation to be in a fatigue instead of a physiotherapy. I know most of you refer your patient to physiotherapy and you acknowledge the importance of the physiotherapy. So we are struggling with the fatigue with the patient. So fatigue in general, it's a feeling of being extremely tired, usually because hard of work or exercise and lack of sleeping. This is where we are experienced. All of us, we are experienced as a human being. But is it similar to the patients with rheumatoid arthritis? No, actually. What they are reporting, patients describe their fatigue as annoying, multidimensional symptoms with a far-reaching consequence for daily lives. 40 to 8% of rheumatoid arthritis patients report fatigue. So that means we have to consider, and when we design a protocol for the patients with rheumatoid arthritis, we have to consider the fatigue. That means it's not going to be rest. They will have a rest, then they will come next day will be in a good shape. No, it might be the other things that's going to be affecting them. So the impact of fatigue is going to be decline in their function, worsen mental health status, higher level of interpersonal stress, will going to be also greater health care utilizations, and they're going to be from department to department due to the fatigue itself. Is not going to be due to the disease, the rheumatoid arthritis disease or something like that, due to the fatigue which is coming as an outcome. So what's the importance of how is going to be the etiology of the rheumatoid arthritis? Actually, the main three things, disease process related factors, which include the inflammation, pain, and functional limitations. And there are two things that is not disease related, which is the behavior factor or personal factors. So inflammatory biomarkers that's going to be, we acknowledge that they are increased, elevated with rheumatoid arthritis, especially TNF6. That's going to be affecting with the fatigue, as has been shown that as long as the inflammatory biomarkers increase, the fatigue scores is being increased as well. Also the pain, as long as the changes in the pain is increased, the fatigue as well increased. So there are really a positive correlation between the fatigue and pain itself. Also the function limitations. With the rheumatoid arthritis patients, they have a really function impairment, which leads them to have highly effects on their fatigues and their function levels. So they need extra activities to do an exercise or to visit their physiotherapist. In other hand, the non-rheumatoid arthritis specific cause of fatigues, psychological, psychosocial, and behavioral, and cognitive and physiological changes. The first one, the depressions. We extremely know that they are depressed. Depressed mood is one of the most consistent predictor of fatigue in rheumatoid arthritis. In addition to direct association between depressions and fatigues, depression has a recognized association with a systematic inflammation, particularly CRP and IL-6. On the other hand, also the behavior, sleep disturbance. 65% of rheumatoid arthritis patients reported sleep problems such as poor quality of sleeping. Studies in rheumatoid arthritis patients have linked sleep problems to a number of poor health outcomes, including fatigue as well. It's as been mentioned just earlier that the patients with rheumatoid arthritis, they are obese. So physical inactivity is related to depressions, sleep, poor sleep quality, and increasing the obesity, which is directly to those are directly correlated with the fatigue in the patients with rheumatoid arthritis. Patients with rheumatoid arthritis, they are changing in their body cell mass. So gonna be low muscle mass and muscle density have been noted in rheumatoid arthritis and have been attributed to chronic inflammations. In terms, low muscle mass or quality has been linked to weakness or poor functional. Low level of activity may also result in a muscle weakness through deconditioning, like a poor cardiorespiratory fitness, impairment of muscles functions, and muscles or wasting could be reduced function capacity, which in turn increase the levels of fatigue. Taking this slides and the slides before, that leads us to also the general self-efficacy. We have to increase the self-efficacy of the patients towards their management, either through exercise or their medications. Exercise, then, by the end, that means exercise is going to be help. We know that's going to be help improving the self-efficacy, decrease the obesity, improve their sleep disturbance. So all of those variables are going to be improved by exercise. So we have to like when we designing the protocol for the patient with rheumatoid arthritis, we have to acknowledge their fatigues and the importance of the exercise at the same time. So we have to improve their physical activity as much as we could. So thank you so much.
Thank you very much, Dr. Anas. Kindly, Dr. Anas and Dr. Ru'a to come in the front. We will open the floor for questions and comment.
Thank you, Dr. Ra, Dr. Anas. My question, Dr. Ra, would you advise to refer psoriatic arthritis patients from day one to a dietitian and a physiotherapist?
It depends. As I mentioned before, that the prevalence of obesity is very higher in patients with psoriatic arthritis. So if I found that my patient is having an obesity, he needs, of course, from day one, to refer him for a better control of his weight, for optimal working of my therapy. So this is, there was many studies which was done on the effect of the obesity in psoriatic arthritis patient. So this is one point. The second point, the presence of obesity increases his risk of having high cholesterol, high blood pressure. So I think, yes, I will collaborate with the other specialty for better outcome of the disease.
I also have a question for Dr. Anas. Are there any restrictions on when you develop a program for a patient with rheumatoid arthritis? Do you have any, for example, restrictions or preferred regimen for patients with RA compared to osteoarthritis patients or patients with sport injuries?
Thank you so much for the question. Actually, there is no actually specific protocol. You have to tailor the exercise protocol for the patient themselves, first of all. The second thing, as I just mentioned, that we are really facing, as a physiotherapist, we are really facing the fatigue patients. Like 2 days, okay, they are fine, they will do exercise, they are excellent, and the other 2 sessions, they are absent, or they will show up with like low mood. So we have to consider just mainly, we're gonna just, definitely it's gonna be different a little bit on sports injuries, but still they have to going to be just a general exercise programs. It's not going to be that specific, but we have to just consider and improve the things that are related. Obesity, self-efficacy, improve their moods. That's going to be affecting on their and their physiotherapy program.
Okay, I have questions. Thank you for all speakers. For Dr. Arua, regarding the surgical, bariatric surgery, so have you across any, bariatric surgery that resulted in patients with psoriatic arthritis reduce their risk from cardiovascular point of view or metabolic syndrome? This is just for the first question. The second question for neurologist, Dr. Fahad, regarding the infliximab. As an entity in F, it's immunoglobulin, and there are some sort of questioning whether they can cross the blood-brain barrier. So is there any other study ensuring the bioavailability of the immune medication on the CSF? Thank you.
Okay, thank you for your question. There was one study that have looked to that in patients with psoriasis, but unfortunately there is no any study that have looked to that in patients with psoriatic arthritis. And for the study that have looked to the effective bariatric surgery on patients with psoriasis, it shows a good result that patient achieved minimal disease activity and they have a good outcome of the disease when they underwent a bariatric surgery.
Thank you for your question. I will answer it from
Excuse
two
me,
ways.
Dr.
One, if you look at the animal model of infliximab, there was a good data to support that there was a good penetration to the blood-brain barrier because the molecule have all the characteristics that making it susceptible to crossing the blood-brain barrier. So that's one. Two, I think if we ignore that point and we are just concentrating on the clinical effect, it's clearly obvious that this drug is able to arrest the disease activity. And maybe it's arresting the disease activity peripherally or extra the CNS, so making the transmigration of cytokines and lymphocyte to the brain is less. So I think I tend to think in a pragmatic way, is that this drug is controlling the disease, so regardless of what it's doing at the molecular level, it's doing the job.
Yes, I'm Abdullah Fraid from Qasim, MOH. Thank you for all speakers. My question to Dr. Fahad Al-Ajlan. Thank you for presentation. What about cyclophosphamide? So you mentioned infliximab, but about cyclophosphamide? You are using this usually, or this is the trend of King Faisal to use infliximab usually? And the second question, regarding the data of Dr. Said Bouhlega about oral ulceration, was the presentation with oral ulcers or no? Because the challenge in diagnosis of Behçet, sometimes they didn't present with oral ulcers and they present with neurological or neuropsychiatric manifestation and missed for a period of time, then you cannot do anything. Thank you very much.
Thank you so much. So, for a reason or another, sorry if I take time. Last week, we spent 2 hours with rheumatology fellows explaining to them the neurorheumatology, explaining cases. When it's come to the IV cyclophosphamide, the only reason we use it as a neurologist with the rheumatologist, the indication that we push for it is primary CNS vasculitis. However, for Behçet, it's our experience, but our experience was built on the literature, is that infliximab is the drug of choice. If you are not a big fan of infliximab, then etanercept can be the second choice, and the third choice could be adalimumab. So, but by far, infliximab was our way to go. Your second point is that about incomplete Behçet. Yes, we have 2 cohorts collected at our hospital. One of them was 10%. The second one was, I think, 12 or 16%. And this is the challenge. The challenge is to deal with incomplete Behçet before the full-blown manifestation of Behçet is developing.
Yeah, if you allow me just to comment about the role of cyclophosphamide in neuroBehçet. Actually, as you know, we are lacking the high hierarchy evidence to support this therapeutic strategy. However, most of the case reports, case series are supporting the use of cyclophosphamide in neurobahjat. There are some evidence about the TNF inhibitor, as Dr. Fahad mentioned, but usually we reserve TNF inhibitors for the mucosal ulcerations, for the ocular manifestations. But the CNS manifestation, usually we need to be a bit more aggressive. And cyclophosphamide probably is a better choice for CNS manifestation in a patient with Bahjat disease.
Okay, thanks for our speakers. Hana Al-Asami, Major Hospital, Jeddah. My question for Dr. Ru'a, did you come across the diabetes as a risk factor in metabolic disorders in patients with psoriatic arthritis?
Yes, so as I shown in some of my slides that because of the pathogenesis of the disease, that the risk of diabetes is very high. It's reached up to 40%, especially that because of the inflammatory marker, they cause insulin resistance, and this increases the risk of diabetes mellitus. Yes.
Next.
Excellent presentation, guys. Well, good to see Dr. Ru'a again in the Saudi way. I have a quick question for Dr. Fahad, and sorry you're on the spot. We love neurologists. I think the real question is, why really 7 days of a gram? Now, I understand that you guys love steroid. That's part of the passion. Do you have any data specifically to support a gram per day for 7 days versus any high dose that I can make out of my mind?
Sure. Really, this is a good question. You know, this is the communication between rheumatologists and neurologists. So if you want to base your decision on a data in Bahjat disease per se, we don't have. But you know, when you are short on data, what you do is you extrapolate from other subspecialty. In neurology, when we have a severe brain inflammation, regardless of the etiology, the common practice, the literature supporting going for 7-day pulse steroid instead of 3 or 5 days. And we do believe that 7 days is able to suppress the inflammation. And actually, if you look at the Turkish literature in 2012 of neurobahjat, this is the regimen they propose to use, which is 5 to 7 days. I'll tell you something, you know, I'm not disregarding Bahjat, don't get me wrong, but the disability and the morbidity will come from the neuro part. So if we are not aggressive with the disease can hurt us a lot. So that's why even if the data is supporting it, and this is the consensus recommendation, is that we need to go aggressive. And we are accumulating good data. That's those patients, you need to go with high dose steroid, you need to go with infliximab. It is not the best quality of data. And to be honest, if you're gonna wait for a good quality of data in neurobahjat disease, probably you're gonna end your practice before seeing it.
Okay. Excellent. I think it's room for really a good study, because obviously you would, although I do respect the part about the neurological involvement, we all know that if we keep them in a high dose of steroid, we also can really lead to morbidity and mortality from other areas. But it's worth looking into that in a trial that can be multifactorial trial designed to treat either cyclophosphamide versus infliximab or another anti-TNF. And within the same trial, we can randomize a patient into pulses, high doses, conventional steroid versus lower doses later on. And if you guys are interested, we can form a work group, and it should be product of this conference.
You know, I'm in the mental of clinical trial sets, but you know, the index case here is rare, and the event rate here is rare. So always it's good to have a randomized clinical trial where we have a high number, but there is a word before this, which is the feasibility.
Yes.
You know, I'm not sure how feasible is this, because neurobahjat, I don't think if we collect the data, we'll end up with having a big number of it. Second thing, the event rate that this can discriminate between the two drugs is very low, because both are doing good job. This is not something like immunomodulatory therapy versus the traditional. This is another level. So I'll be interested, I'll be pushing, but I will be a bit reluctant to go forward before having the data really consolidated.
Excellent. Thank you so much.
Okay, thank you very much. At the end of this session, I would like to thank the speakers and the audience. Thank you very much.
I'd like to thank our guest speaker about the informative, nice presentation. This is a time to give the trophy for the speakers and the certificate for the chairperson. Professor Basil Zurqani. دكتور أنس الدهيش. دكتور فهد العجلان. دكتور علي رحيلي. دكتورة حنان العصيمي. دكتور عطية الحوري. الدكتور وليد وادي. الدكتورة غادة الجنوبي. الدكتورة معتوقة باعامر. الدكتور عبد الله الفريج. الدكتور بدر المحمادي. يعطيكم العافية، شكرا جزيلا.